dais, team from the UK IAPS. Thanks very much for having me here. It's my first visit to SGPGI, and it's a wonderful, wonderful facility you have. It's a pleasure. It's also fortuitous that today is 13th of August and it's the Organ Donation Day, the World Organ Donation Day. And I think as surgeons, as physicians who look after children with chronic diseases, I think it becomes imperative that we are advocates for pediatric transplants and we encourage organ donation across our society in whichever way, in whatever way that we can. So I think this is a very, very fortuitous day for giving this talk. So I will proceed to the next logical thing in biliary atresia, which is transplantation. A little bit of history, I think, is always useful to give perspective to what it is that we are doing. This is a beautiful book, and I think those of you who haven't read it, as a surgeon, even if it's not transplantation, it's just very, very motivating. I would recommend that you please read it. And the person who has done maximum for transplantation across the board, whether it is donor surgery, whether it is respiration surgery, whether it is organ retrieval, is this man, Thomas Tarzan. And he reported the first organ transplant, the first liver transplant way back in 1963. And one of the children operated was a 3-year-old biliary atresia. Remember that this happened before the first Kasai report came. The first Kasai report came in 1968 with a 10-year follow-up. So 1967 was again a biliary atresia child when they had the first successful transplantation. So actually transplantation for biliary atresia precedes Kasai in literature. Though obviously when Kasai reported, he already had 10 years of follow-up on his procedure. So over the next 3 decades, I think all these things have got refined. But as you can see from the previous discussions, a lot still needs to be addressed. In most countries today, or at least theoretically today, biliary atresia is not considered to be a fatal disease. The reality in our country is different. I will touch upon it later. But in most developed societies, biliary atresia is no longer considered a fatal disease. Unfortunately, in our country, it's still very much a fatal disease. Now, let's go on from the Kasai. So, what is the native liver survival after biliary atresia? This was an old paper that came out way back in Lancet, and it says that if you transplant, you have about 80% survival. If you don't transplant, you only have about 50% native survival. This figure has moved up and down a few percentage points, but has really not changed dramatically. So a rule of thumb, about 50% of patients will survive long term with their native livers. They survive with native livers. They are not normal. So native liver survival is a euphemism. It is not that they are normal, but they survive as against those that are transplanted where there is a better survival. Okay. But definitely the portoenterostomy has improved survival because it has pushed mortality from where it used to happen in early infancy and childhood to much later where children can have other forms of treatment. All right. There is various pros and cons, various scores, various things that we have discussed over the morning about how to predict outcomes. To be fair, you cannot. There is only data that is available that came again way back in 2001 that if you operate early, more of them tend to survive on their native livers. If you operate late, less of them survive. This is a rule of thumb. It is not 100%. And we will address this when not to do Kasai a little later in the talk. So this is the only thing that we know for sure. Everything else is a little bit ifs and buts. So as far as possible, operate early. When you can safely get that kid in and out of a major operation. Don't take a newborn for Kasai procedure when you are not sure you can get that kid out of anesthesia and surgery, because the child might die of complications of the procedure rather than from the biliary atresia. So there has to be an optimal time, and that optimal time will vary, but definitely within the first 30 to 40 days, 45 days. So what happens to these patients who survive after Kasai portoenterostomy? As I said, the numbers vary. It is 60% somewhere, it is 70% somewhere, but they have significant morbidity. They are not normal. They have growth failure, they have symptomatic splenomegaly, they have portal hypertension, they are jaundiced, a lot of them have compensated cirrhosis. So they are getting on in life, but they are not normal and they continue to require medical attention. However, depending upon where you read, about 2/3 of patients or 70% of all biliary atresia patients will need a transplant when they are children in their pediatric age group, and the remaining maybe later on when they are young adults. However, what Kasai portoenterostomy has done, as I told you, has pushed that need for transplantation into older age groups and not when they are infants, when transplantation is more difficult, more challenging, and more difficult to manage. Therefore, Kasai today should be considered as a bridge to transplant rather than an end treatment by itself. Unfortunately, for a lot of patients in our country, that is all that they can have. empty hand how we do it. We do it well. We try to optimize outcomes. How do we predict outcomes of the site? Again, there has been a lot of discussion. It's a very simple thing. Again, only the data that is hard and available is this. If you have a good durability at the end of 3 months, your chance of surviving on your own liver is about 85%. If your availability is more than 6 milligrams per deciliter at 3 months, your chance of surviving on your liver is very low. Similarly, if you have cleared jaundice at 3 months, you have a good chance of maintaining your own liver for a long time. If you have not cleared jaundice by 3 months, very, very few people will survive. So this is an easy rule of thumb. And from a practical point of view, it's easy to say that if you have done a site today, at 3 months, if you have not cleared jaundice, high, this patient is unlikely to survive in any liver. And you have to consider transplantation. That is all the message that I have to give. And I think from that point of view, this is a very important slide. Now, I will come back to this data a little later because I think it is illustrative of the point that I was trying to make. Today, and in most countries in our own setup, more than half the liver transplants that we do are from Biliary. And that number is increasing the more issue that we go. You can all think about this, but when it comes to smaller children in early infant, in the first 2-3 years of life, almost 70 to 80% of transplants that we do are from Biliary. Right? So, why the children with Biliary Atresia need liver transplant? That is taken from the other way. There are a whole series of indications why they need. When you are young, in other words, you have done the SI has not worked well, then it is more likely that the indication for transplant would be persistent jaundice, would be recurrent meningitis, or would be liver failure in younger children. As your Kasai works and if the child grows and becomes 5, 7, 8, 10 years, then the indication for transplantation might be gastroesophageal varices, resistant portal hypertension, severe hypersplenism. They become indications for transplantation in the older children. So as you can see, these are easier to manage than this and this. So the older your child gets, the better health he is in. So a well-done Kasai gives you that option. It gives you the option to push this into later childhood where the child is more robust and can withstand procedures in a better way. The other indications for transplantation, as I said, in our country, late diagnosis of biliary atresia is still a problem. I think Yogesh mentioned it. It is a problem. Despite whatever public education goes on, we still see significant number of patients coming late. That 100 days is a sort of, again, a rough figure. We will address that a little later. But when this child comes late, when you feel the liver, it is very hard. The patient has ascites, has evidence of portal hypertension. Then there is no point. This child has liver cirrhosis and portal hypertension, and Kasai is not going to fix that. All right. One of the other things that is useful is if you have a child coming with biliary atresia, child has got a prolonged INR, you are giving vitamin K, you give 3 doses, 5 doses, the coagulation does not get better. In other words, this child has no liver reserve. It's unlikely that this child will tolerate a Kasai procedure. You're likely to have high morbidity after these procedures. So these are probably children that you would think would require transplantation. Intractable pruritus, that was addressed a little earlier, is an indication, not common, but yes, it is possible. Hepatopulmonary syndrome, portopulmonary syndrome, all that has been discussed. Hepatic malignancy has been discussed, so we have gone over this already. Right, so you have done a Kasai today, and when do you decide that the Kasai has not worked and this child needs to go for transplantation? Because that becomes a very important question. Now, you might refer a patient to transplant unit if he has not had a Kasai, or you have explored the liver is cirrhotic, you have not proceeded. So there is no Kasai, they need to be referred at diagnosis. So you diagnose today, Kasai is not possible, refer to transplantation unit. You have done a Kasai, but there's an early post-operative failure. That means at the end of 3 months, your bilirubin is still high, the jaundice has not cleared, please refer to liver transplantation unit. If your Kasai has worked in the early years, follow up the patient very carefully as has been addressed, and if over time the patient develops decompensating liver disease, develops significant portal hypertension that is not easily controlled, develop significant nutritional deficiencies, develop things like hepatopulmonary syndrome, etc., it becomes an indication to refer. So at each stage, the indications change. All right. So, and that's how you decide which patient to refer on to transplant center. Please remember that referral to transplant center doesn't equate to transplant next day. It is just involving another team to optimize this child as we go forward. Generally speaking, across the board, this is a large Japanese cohort of almost 2,000 plus cases. The average age of operation is around 4 to 5 years of transplantation in their cohort. In our cohort, it's much younger. And it's potentially most children require transplantation in the first decade of life, a significant number in early infancy. In Japan, as I told you, their outcomes seem to be better generally, and those children come for transplants when they're a little older. Now, what happens when you send a patient to our unit or you send a patient to a transplant unit? What happens? We would recommend an early referral because it allows time to build rapport with the patient. These are all high-risk interventions and you need to build up a rapport. You can't get the patient today, operate tomorrow. You have to evaluate a donor and that takes time. Optimizing the child is extremely important, and despite whatever we say about nutritional rehabilitation, sarcopenia in these children at presentation is extremely high. It's extremely high, and in the community these patients are not looked after. Unfortunately, they are not looked after. They come to us in very poor shape. A lot of them have severe infections, they have cholangitis, they have bacterial peritonitis. So all these things have to be optimized. A lot of these children require an accelerated immunization protocol because you need to complete all alive vaccines before you transplant these children. You need time for evaluation, you need time for counseling, and most importantly, you need time to raise funds. So it's important that the referral be made early so that the transplant team then has time to build all this over the next few weeks or months and optimize the child's condition so that your outcomes are likely to be better. Now, I think this is important, and this goes on what previously was followed. The impact of sarcopenia in infants with liver transplantation, who come for liver transplantation, who have got biliary atresia. So it is extremely high. So when you have sarcopenia, they measured it by doing a CT scan and measuring the area of the psoas muscle. And when you have sarcopenia, your operating times are longer, you have a higher amount of blood loss, you have portal vein stenosis risk is high, bloodstream infection risks are high, and overall survival after transplantation is poorer when your child has sarcopenia. So I think as community doctors and as specialists sitting in institutions, we have to spread this message that these children have to be looked after. We should not treat them as a dead end case because you don't know 5 years after the line, 5 years down the line, all governments might be sponsoring transplants. We do not know that. So our business is to keep them going until that point of time. So once they come to the transplant center, we select donors. In our setup, in most parts of Asia, about 90% of them are living donors. And I think biliary atresia patients are ideally suited because they're ideally suited for a living donor left lateral segment because the operation itself for the donor is of less extent. It's a smaller operation for the donor recovers faster, and it is optimal for the child. So this is, in our setup, this is the most common thing that we do. So a living donor left lateral segment. The other ones are available. So as I said, in our own experience, almost about 10% are disease donors, 90% are live donors, usually one of the parents. A little bit about the procedure. I will not go too much in detail, just about what is specific in biliary atresia as we go forward with transplantation. Anesthetic preparation, all of us are aware. We have discussed this in the past. You need good access. It's a long operation. You need invasive monitoring. Temperature regulation is very important because the whole abdomen is lying open for hours together. There is a lot of fluid leaking here and there. So you have to maintain temperature. And once the patient gets hypothermic, they get acidotic. Once they get acidotic, their coagulation cycle goes off. Operating on them becomes very difficult. They get hypotensive. They don't respond to inotropes. So managing them is very difficult if they get cold. So temperature regulation is extremely important. Point of care monitoring and testing is important. So today, almost all tests can be done point of care. You don't need to send anything to the lab. All the required tests intra-op are done point of care. You must have adequate blood products. Now the laparotomy, as far as possible, we will go in through the same incision that was made for the Kasai. If the child had a Kasai, often what happens is like what we discussed with pyloric stenosis, the scar climbs. Often the scar is at the subcostal area and you really cannot use it. You have to make another incision. But that again, it varies upon how the child is. This is the liver as how it looks. It is usually macronodular. It is very cirrhotic. There are a lot of bile lakes that are there here and there. The child has had previous Kasai, has had previous surgery. Sometimes they have had re-explorations. So the whole abdomen is stuck. They have portal hypertension. So each of the adhesion is vascular. So getting the explantation is a little difficult. So all these add up. So previous surgery, ascites, SBP, portal hypertension, they all make it a little more difficult as you go. Once the liver is mobilized, you can see the nice blood vessel. There is no biliary tree here because this is a child with biliary atresia. So here is the hepatic artery, here is the portal vein. Then the liver is taken out, and once the liver is taken out, you have what is called an anapatic phase. That's the top IVC, bottom IVC, and then you have clamps on the portal vein and the hepatic artery. Now there is the whole circulation is clamped. Most of the children with biliary atresia have good portal hypertension, and because they have good portal hypertension, even if you clamp the IVC, nothing happens to their circulation because blood circulates through the collaterals and reaches the heart. So they tolerate this very well, as against those where we are doing it for metabolic disease where they have no portal hypertension. So in biliary atresia, this is really not too much of a problem of cross clamping. But ideally, you want to keep it as short as possible because blood is collecting in your infradiaphragmatic area. It is all becoming rich in acids and everything. So when you unclamp, all that acid and all that cold blood goes and hits the heart. So as far as possible, try to keep it as quick as short as possible. Meanwhile, the donor team is harvesting the organ. You do bench work, you prepare the organ, you perfuse it, you cool it down, you wash out all the blood, you do whatever venoplasties are required so that you can just go and put this liver into the patient. The liver is put in an orthotopic position, so it is put, the left lobe is put on the left side. If you're using right lobe, you put it on the right side under the diaphragm. So it's a very, very orthotopic kind of repair. So the process starts with IVC first. So usually what we try to do is a triangular anastomosis of the hepatic veins to the IVC on the anterior wall. You close off the native hepatic veins because often they are quite thin, often quite small because of the cirrhosis. So you do that first. You then do the portal vein. Now this is important because in portal vein, usually in biliary atresia, the portal vein is often very sclerotic because there is inflammation in the porta. And the portal vein is often very narrow. Often it is 2-3 millimeters in size. It is very, very thick walled. And you have a big discrepancy between the donor portal vein and the portal vein in the child. In addition, because they have a lot of portal hypertension, there is very little prograde flow towards the liver. So all the blood is going through collaterals. So when you put the liver and perfuse, no blood comes to the liver. So you need to optimize, you need to augment the portal flow to try and get more and more blood coming to perfuse the liver, because the two things, portal vein flow and hepatic artery flow, are important, because if they don't happen, then that graft dies. So it is important to do all this. So you do careful ligation of all collaterals. You do ligate the coronary vein because often it's the major source of drainage. Sometimes you can even ligate the left renal vein because in all your shunts, it's coming through splenic vein, left renal vein, IVC. So again, there is enough collaterals and all the blood starts to come back. So you need to do all that. You might need to do some venoplasty to try and get good portal flow. And this is by far the most important step as far as I think at this stage to get things going and have a successful outcome. Once this is done, the clamps are opened, the liver is perfused only with portal blood. You wait for the anesthetist to catch up, correct all the, the acid, correct the electrolyte disturbances, correct the bleeding, and wait for some time till things settle down. And once that happens, you have hemostasis. You then go ahead and do the artery. We call our microvascular colleague comes and does the artery for us, because we used to do the arteries earlier. We had an unacceptably high level of hepatic artery thrombosis. So we have now moved to microvascular anastomosis. They come and do it with 9/10 or nylon under microscope. And since then we have had, touch wood, not too many hepatic artery thrombosis problems. Here in the hepatic artery as well is usually very, very enlarged because it is cirrhotic. There is no portal flow. Compensatory hepatic artery enlargement takes place. These patients often have high amounts of cholesterol, so they have plaques. So these arteries also are not normal. They are quite friable and they need careful handling. Once that is done, you do the biliary enteric anastomosis. This is standard. All of us are very familiar. The same type of anastomosis that you would do for a colorectal cyst, for example, multiple interrupted sutures onto the old pre-existing roux loop. Oftentimes the roux loop gets short because there is no bile flowing through it. So what you leave as 40 centimeters at the time of operation, when it comes for transplant, is hardly 10-15 centimeters. So sometimes it needs to be mobilized, sometimes it needs to be freed up, and the reloop needs to be modified before you can actually use it. Once you finish closure and you shift the patient, usually basically a lot of it is hemodynamic monitoring, fluid electrolyte monitoring, sepsis surveillance. But these are standard now, and most intensive care units are perfectly capable of looking after these children. Usually after a period of time, over a matter of 1 or 2 days, things start to settle down. If your liver is working, things get better and the child rapidly recovers. Usual ICU stay is about 7 to 10 days. Usual hospital stay all put together is about 4 to 6 weeks. So how is liver transplant in biliary atresia different than those for non-biliary atresia? Now this is our data. So as you can see, the patients who undergo transplantation for biliary atresia are much younger than those who undergo transplant for other indications. So they are much younger. Similarly, they are much smaller. So our average weight is only 8 kilograms as against somebody who is much bigger. Similarly, most patients who have biliary atresia undergo living donor transplants in our hands because that is by far the easiest to do, and you can do it when the baby needs it. Whereas most other diseases which are metabolic, the patient can afford to wait for a cadaveric graft, and some more cadaveric grafts can be used when you have metabolic diseases when there is no urgency. All the other complications are more or less the same. So despite it being a more difficult operation and more technically challenging, outcomes are similar between the biliary atresia and non-biliary atresia group. Similar data has come from Korea. And similarly, when you transplant primarily and when you transplant after Kasai potoenterostomy, there is no difference. So by doing a Kasai potoenterostomy before, you are not in any way damaging the child's chances after a transplantation. So Kasai is something that is advocated without too much doubt. Again, here, the risk of complications are higher when you do a Kasai and then patient has transplants, but overall outcome really it does not make any difference. They are all more or less same. So the having a Kasai done before does not damage or influence the outcomes of liver transplantation. The same message is being conveyed here as well. Now, I will summarize by a few questions that we get asked repeatedly. The first question that we get asked is, I have this child. I feel the child is little older. Should I do a Kasai? Now, I think the answer to that question is a very, very forceful yes. You please attempt a Kasai unless there are serious contraindications. If your diagnosis has changed from biliary atresia to cirrhosis with portal hypertension, Kasai is not going to work. But if your diagnosis is still biliary atresia, please attempt a Kasai. Even if the child is 70 days, 80 days, as far as you have it set up where you can look after these children. The last thing you want is to attempt a borderline Kasai and then lose the patient from surgical complications. That's not what you want. So how much risk you're willing to take will depend upon the institution that you're working in. But as far as possible, please perform a Kasai when it is indicated. Don't take somebody with cirrhotic liver with ascites, portal hypertension for Kasai as an exercise. Chalo kuch nahi hai, chalo karo. Patient is going to die. That's not the right way to do it. And unfortunately, that is how it is. We trained in that background. Unfortunately, the first Kasai I did was in a grossly cirrhotic patient. So I think that's how it is, and I'm sure it continues. Why do I say that? Because it extends survival and pushes the need for transplantation into later childhood or young adulthood, where the child has a much better chance of receiving the transplant and surviving it successfully. The second part is having a Kasai does not influence the outcomes of liver transplantation. So the outcomes are as good. All right. So it is important because it does delay the need for transplantation when in older children. However, this is a theoretical concept in the assumption that most children will get a transplantation. In our country, unfortunately, that is not the case. Out of 78 children with biliary atresia over a 5-year period, ultimately, the only patients who survived were 20 plus 15, 35 plus 9, which is 44. So it's about 60%, of which some had transplant and some are native liver survivors. A lot of patients either died or were lost to follow-up, and this is an unfortunate reality in our practice. Despite having the technology, we are not able to offer it to more and more patients. So unless this becomes commonplace and every public institution does this on a regular basis, these numbers are not going to change. And I think that is the reason why I started by saying we must advocate for transplantation, we must advocate for organ donation. When not to proceed with Kasai, when the liver is cirrhotic, you know it is cirrhotic. Poor liver is and again, this is days, 60 days, 90 days, 100 days, age is just a number. So I think more important is this. If the liver is the liver left to recover, then please go ahead. If not, please not proceed. When do I refer a child to liver transplantation? I already alluded to this. To the Kasai, refer. If you do the Kasai at 3 months, your child has jaundice, is more than 2. Refer. If your Kasai has worked, later on the child has a problem. Cirrhosis, portal hypertension, chronic liver disease, hepatocyte syndrome. If in doubt, refer. They will send it back to you saying, no, we do not want to do it. All right. We must remember that when we keep talking about transplantation, pediatric recipients are special. They are different, and we have to factor in that in all our decision making, because we are giving this child lifelong burden of, they already have a lifelong burden of organ transplants and of multiple transplants, perhaps of organ failure. I think this was alluded to in the previous talk also. Once you have a chronic organ failure, it is with you for life. Whether you have a transplant, whether you don't have a transplant, you are a patient with an organ failure and your life has changed forever. So they already are carrying that burden. On top of that, we give them problems of immunosuppression. So that decision to transplant has to be very, very calculated, has to be very, very carefully done, because immunosuppression even today has significant adverse effects. And you can imagine somebody's immune system we don't understand primarily. And from 6 months of age, 8 months of age, we start manipulating the immune system. We do not know what happens to these children going forward. A lot of them develop PTLD, they develop lymphoproliferative diseases, they develop metabolic syndromes, they develop renal dysfunction. So these are things that we have to be aware of. They have risks of infection, CMV, EBV, plus whatever other seasonal infections that all our children get living in a tropical country like ours. Significant number of them have developmental and psychological issues, and these need to be addressed as they grow older, especially during teenage. So this is a statement that is often repeated. Biliary atresia is now a treatable condition with up to 90% of infants expected to survive in centers offering sequential PE and liver transplantation. And this is a fact. The problem is the fact is not translated into practice, and it will remain like that as far as transplantation remains restricted to private institutions. It is only going to happen when it is taken up in a large enough format in public institutions where it is affordable, not only the transplant, but also care of these patients after transplantation, which actually is more challenging. The transplantation you can do, it's a one-time thing. So this is an important message. I will stop with this. This is Shreyas. Shreyas, we operated at about 65 days as biliary atresia. It worked partly at 2 years of age. He underwent transplant, and he's now in engineering college, and they do extremely well. He's not had one rejection, one cholangitis, one everything, but he's the exception. Otherwise, these children require a lot of work, but there is light at the end of the tunnel. So I'll stop here. Thank you very much.